our next presentation is by Chloe Dann. Chloe is currently doing a undergraduate degree in medical radiation science, and her presentation, which I'll just bring up on screen, is investigating virtual reality assisted assessment of type B aortic dissection for preoperative planning. So if ever you need to do one of these sort of procedures, now you'll be appropriately briefed.
Hi everyone, my name's Chloe Dann. As you heard, I'm a fourth year medical imaging student, and my project that I've done over the past 10 weeks that I'll present to you today is titled Virtual Reality Assisted Assessment of Type B Aortic Dissection for Preoperative Planning. So my supervisors were Professor Zhonghua Sun, Dr. Shirley Jansen, and I had a lot of technical support from Carly Tillett here at the HIVE. So I'll just start off with a little bit of background information for those who aren't familiar with what an aortic dissection is. So up on the screen is some CT slices. When we talk about an aortic dissection, we're talking about the aorta, which is the main blood vessel in the body. It takes blood from the heart and provides it to all of your organs and limbs and everything else. So the first image up there is a normal aorta. We expect it to be a singular tube, which the blood would flow through. In an aortic dissection, what happens is there's a tear in the wall of the aorta, and blood creates a second channel within the aorta, and that's what you see up on the second and third slices. The third one's just highlighted for you. So you can see that where it should be a single tube, it's now become two tubes. One we call the true lumen, which is what the blood should flow through. That's the normal part of the aorta still. And the false lumen is the blood-filled channel that's been created. And then the part that separates them is just referred to as the intimal flap. So this pathology causes quite a few problems within the body, which I'll explain in a moment, but we can classify them in a few different ways. The main way being we talk about them as type A or type B. Type A and type B are different anatomical places within the aorta. So type A can be from the ascending aorta onwards, whereas type B is distal to the subclavian artery. So that's the image on the right side of the screen there for you. So complications of the type B aortic dissection, so what it actually does in your body, it causes malperfusion of abdominal organs. So this means basically like your kidneys or your intestines won't get the blood flow that they need to function correctly. This can lead to a lot of issues, including ischemia of the organs and death of them as well. And other complications include like rupture of the aorta, which can lead to internal bleeding, and then ultimately death if no medical intervention is performed. So what was my research about? So basically I study medical imaging, so we're looking at different types of medical imaging. So CT images, which I showed earlier, are slice imaging. Currently this is how these pathologies are assessed for preoperative planning, but there are limitations that exist with using CT. They are 2D slices, so it's hard to appreciate fully the relationship that this pathology has and all the different branches that come off and how they are affected. So virtual reality, this project demonstrated how it has the potential to assist in assessing associated arterial branches, geometry of the dissection, and ultimately assist in planning for a more informed endovascular surgical repair. So this project is being undertaken to investigate if that is clinically useful for this type of treatment. So it is important to note also that type B aortic dissections are an area of controversy. The point at which they are determined as a surgical candidate or if they should be medically treated is controversial, whereas when we look at type A aortic dissections, it's more sort of straightforward. Surgical intervention is what goes ahead. So again, just the aim of the project, looking at the usefulness of can we use VR to assess type B aortic dissections, and is it useful when we compare it to the traditional imaging method, which is CT imaging. So what I got out of this project, or what was completed, was firstly there's two major software packages. I'll talk about segmentation, which is basically taking those 2D slices and turning them into a 3D model, which is what you saw on the slide here, that model, that's a segmentation. So basically I used 2 different software packages and I was able to compare which ones were better, because ultimately the idea is this would be used in the clinical setting and it needs to be easy, seamless and quick to be able to use. So looking at the softwares and which one was better in these regards. Secondly, producing the 3D models of the aorta, which I'll show you on the slides and you'll also get to see in the hologram table. Visualising in the hologram table, exploring the workflow of actually getting to the point where you can make it a VR experience and how that would work clinically. And then the stretch goal was to create the VR experience. We're having a bit of troubles today running it in Unity, but hopefully we'll be able to show you a little bit of it after. So the 3D reconstructed models, so I took those CT slices, which we call DICOM data, it's just like the raw data, popped it into a program called Analyze 14, and the models up the top are the ones that were achieved using that software. After I performed that, I decided to also compare it in 3D Slicer, which is another similar software. 3D Slicer is like an open source software, so it had a lot of add-ons that I could install from online to help with the segmentation. So in that regard, 3D Slicer was a little bit quicker in being able to perform this, and the results came out quite nicely as well. And then I picked the model which had the least sort of torturous branches and came out the most fully to use for the VR experience, just so it was a nice smooth experience in the headset. So this is my table just comparing the 2 softwares. So 3D Slicer approximately took about 80 minutes to perform a segmentation, whereas Analyze 14 took about 120 minutes. The differences in the time can be accounted for that obviously 3D Slicer is open source, so I could install a lot of add-ons, whereas Analyze 14, that's not an option. I had to use the given tools that were provided in the software. And a lot of the manual tools edit slice by slice, which when you've got over 700 slices is quite a tedious process. And yeah, so ultimately I decided 3D Slicer had a nicer user experience and it was performed in a quicker amount of time. So looking at, if it was to be implemented into the clinical environment, it might be a better option. So this is the sort of simplified process of how I came up with the actual VR experience. So I started with the 3D model reconstruction, which we performed in the softwares. Then we popped those 3D models into Blender, which is like a creation suite. And from Blender, we were able to extract the center line, which would be the path in which the camera would follow along. I popped this centerline extraction into Unity, where we performed all of the user interface work. So we were able to, add on tools to be able to move forward, backwards, to be able to perform measurements and angle calculations and all those sort of things, and then put it into the Oculus Quest 2. So this is just some images of what was created. So the first image is sort of like a progress pic. Basically, you can see the line running through the aorta, and that's the line in which the camera follows through. The second image is an image from inside of the VR experience. You can see there's 2 channels, one being the true lumen and one being the false lumen. And then there's also labels throughout the aorta which demonstrate the branches that come off, just so that anyone that was actually using it can sort of identify where they are within the aorta, because it's quite tricky once you're actually in the VR experience to identify the branches. So in terms of further work, so there are a lot of hurdles that were sort of encountered as we went through creating this project. Basically, a lot of software issues, things that the software couldn't handle or things that just hadn't been done before, so we had to sort of overcome those and create as we went, which is why it's called research, I guess. So some of the further development that could be carried on would be to improve the user interface. At the moment, it's quite primitive, it's very basic, but it could become something that could be really user-friendly and really intuitive, including functions such as screenshots, which would be a really awesome thing for people that perform or assess these pathologies to be able to take and then save for later on. Including more functions, so different types of measurements or different kinds of movements where they could maybe potentially click and move forward to that point in the aorta. And then obviously looking at the integration into the clinical setting. For something to be used in the clinical setting, it needs to be pretty much press a button and then this happens and then they can use it. Obviously at this point, an 80-minute process isn't something that surgeons are going to sit down and have the time to do. So being able to make this more intuitive and more seamless in the clinical environment would be a big goal. And obviously, what we originally intended was to show this to some vascular surgeons and get their feedback on, is this something that could be worth further performing work on, and is it useful in the clinical environment? However, we had the COVID lockdown on the week it was meant to go ahead, so that unfortunately was cancelled. However, all the ethics approval is there. It's all, in reality, it's really good to go ahead, but we just have to wait until the time is right. So I just wanted to have some acknowledgement. So this project was industry funded by Medtronic, so just a thank you to them for providing the funding for this project. A thank you to the HIVE for having this opportunity available. And a big thank you to my supervisors, Professor Zonghua Sung and Shirley Jansen, for offering their expertise and giving me the ability to perform this project with all the knowledge and the software that I need for that, so thank you. And also a big thank you to Carly Tillett. She offered heaps of technical support. She's a software genius, so thank you to her as well. Any questions? Thank you.